Boston. And oh, again, sorry. So we've already gone through this. We know what is RSD. It used to be called, reflex sympathetic dystrophy. It's now called complex regional pain syndrome. It can happen after a minor trauma, or it can happen after any trauma, surgical or non-immobilization. Even putting a cast on can cause it. And there have been cases where it has happened because of stroke. It's pretty common, unlike what we think. It is very common. There are about 50,000 new cases in the United States itself. And that, I think, is wrong. I think it's a lot more than that. A lot of people just haven't been diagnosed. By the way, the number of new cases of Parkinson's in the United States is 60,000. So we're not that far off. Pain can start in one limb, but it can start in the trunk, the spine, the belly, the perineum, the pelvis, as we said. It doesn't have to be in a limb. It's a very severe pain. It's constant. It's unexplained. It never really goes down. It'll fluctuate, but it still stays at a very high level. There's burning, tearing, shooting pain. There's temperature asymmetry, color change, swelling, and usually the pain is in a larger area than where it started off as. And there's, of course, limited range of motion. Cannot be explained by any other medical condition. Allodynia is pain to light touch. Hyperalgesia is pain to mildly painful stimulus. These patients also present with nail growth changes. The nails may grow faster, they might be distorted, they may be brittle. Hair grows faster, slower, it's usually darker and coarser. Skin changes and skin lesions. This is a picture of somebody with, obviously this is the foot with RSD. She had some surgery here. You can see swelling over here. You can see the marks on the socks she was wearing. The temperature on this foot was 88 degrees. The temperature on this was 94 degrees. This is another one. This is the one with the RSD. You can see the swelling. You see how the swelling compared to this hand. There's some color change. You can see over here. Over here, you can see some color change on this left foot. It's a little dusky in color. There's some swelling on both feet actually. Nails, you can see the nails over here, how distorted, they've actually broken off. They've cracked, they're distorted in shape. This is skin lesions in a patient. I think they're from the same patient. This was after treatment, but these are the skin lesions. Skin lesions can happen. They're not in the diagnostic criteria for RSD, but you can see it. So don't be surprised to see skin lesions. And they can vary a lot. This is somebody with RSD in both arms. The reason I have this is because oftentimes you go to the neurologist or the doctor and they'll say, oh, it's not in one arm. According to the Budapest criteria, according to the criteria for RSD, it should be in one arm. Well, what about if you have RSD in both arms, or all four limbs? This is hair growth. You can see hair growth over here, how thick and coarser it's become to this side compared to this side. So the best way to diagnose RSD is by physical examination. There are really no great testing or tests that prove or disprove RSD. And the thing about a clinical exam by a physician is that it should be done on a bunch of times, at least 2 or 3 times, because some changes happen on different visits. For example, you may have color change today. You may have no color change on your doctor's visit today, but you may have a color change yesterday, or you may have it tomorrow. So we usually tell patients to come back for a second visit when we come up with a more confirmed diagnosis. Tests that are not very helpful for diagnosing RSD. Imaging tests, X-rays, MRIs, and functional MRIs. 3-phase bone scan they used to say, oh yeah, that's the gold standard for testing for CRPS. It's not. We have had studies that have shown that it's not. Bone density, blood tests. Skin biopsy, as Dr. Arias pointed out, is useful for diagnosing if you have small fiber peripheral neuropathy. That may or may not be associated with RSD. A lot of RSD patients do have small fiber neuropathy. That's the only place where skin biopsies would be useful. Sympathetic skin tests are not very helpful. Sweat test, sympathetic skin response. EMGs, I think it's unethical to do EMGs in patients with RSD. But these tests may be useful to rule out anything else. And again, do the test that you think may not make it. As long as the test is not likely to make it worse, have the test done. We talked a lot about central sensitization. So I have the central sensitization for dummies. Okay. We talked about Dr. Alexander's beautiful presentation. Dr. Arias talked about it. I'm going to explain it to you in a very basic way. I look at life very simply, so I'm going to explain it very basically. If I stick a pin in my finger, pain signal, it's still a signal, it's not painful yet. As it travels up my spinal cord into my brain, that's when the signal gets a meaning. The brain reads that signal and says, ouch, that's painful. And then it sends a signal down to suppress that pain. Also, it sends signals to my other arm to rub it, remove the pin, and maybe even make a noise. Ouch. That's normal pain. Pain and central sensitization is different. It's like taking a pen and jabbing it 24 hours, 7 days of the week. When you do that, then there are signals traveling up into my brain, and there are signals traveling down from my brain constantly, 24 hours of the day. When that happens, the spinal cord and the brain, or the central nervous system, starts to become sensitized. Certain changes happen, as Dr. Alexander pointed out. Those are the changes that's called central sensitization. Now, somebody had asked about this question about spread. So if I have RSD in my hand and I have central sensitization, which means my nervous system has now become sensitized. If I do something if I stick a pin in my right hand, that signal, when it gets into my nervous system, is now going to get magnified. And that is what we look at as spread. So, this, again, like I said, I keep things really simple. This is what this brain looks like. Nerves, and there are certain things called glial cells. Glial cells were originally called glia because it means glue. And in the old days, we thought they had no function. They just packed the nerves into your brain and spinal cord. Now we have a better understanding. They are part of the autoimmune system. They do a whole lot of things that we're starting to learn. When you have CRPS, or when you have central sensitization, these glial cells get inflamed. They're now red and hot. When they get inflamed, they release certain chemicals, cytokines, chemokines, all kinds of nasty stuff that come out from these glial cells. That causes the nerves to get inflamed. Okay? So I'm just going to go back on it again. This is an important concept to understand. That's your normal anatomy of the brain and spinal cord. You have the nerves, which are the neurons, and then you have the glial cells, which are the packing cells, part of the autoimmune system. These glial cells get inflamed or activated. When they get activated, they release chemicals called cytokines, or all kinds of nasty chemicals that cause the nerves to get inflamed. The reason I brought this up is because if I did something to treat just the nerve, it's not going to make a big difference, because I need to stop these cells from releasing these nasty chemicals. That's where a lot of our work is, and that's where Dr. Alexander's work is on, is trying to figure out what are the chemicals, what are the drugs, or procedures that can be done to stop these cells from getting activated, the glial cells. A little concept on what receptors are. So most drugs in the human body work in the lock and key mechanism. So we have all sorts of keyholes in our body called receptors. There are specific keys or drugs that fit into specific keyholes. And there are two kinds of keys. There is a key that when it fits into the lock, it opens up the lock, certain things happen in the body. And then there are the dummy keys. When they fit into the lock, but they don't do anything, they prevent the active key from working there. And that's the concept of receptors. So all drugs in the human body work by that mechanism. Whether it's a blood pressure medicine, whether it's your medicine for depression, or whether it's your medicine for pain, they work by that mechanism. So we have the NMDA receptors. In CRPS, what happens is these NMDA receptors, they not only become more sensitive, they also increase, they proliferate. You get lots of these. And that's what we think is one of the things that happens in central sensitization. So it's very simple. If the NMDA receptors get activated, why can't we put in a dummy key that will block these NMDA receptors? There are several of those. The best and the most powerful one is ketamine. There are some other, dextromethorphan and all sorts of drugs. Memantine is one of them, but they're very weak NMDA receptors, blockers. Ketamine is the only decent one that actually does a good job. So let's talk about ketamine and CRPS. So ketamine is a very strong NMDA receptor blocker. We know that. It's one of the safest anesthetic drugs ever made. It is the safest anesthetic ever used. As anesthesiologists, we love it. It's a very powerful analgesic, which means it's a very powerful pain controller. And like I said, in CRPS, the NMDA receptors are activated. The problem is that you can't take ketamine as a pill because absorption is very erratic. Sometimes you absorb a lot, sometimes you absorb only a little, and you have to take a lot more to get the same effect, which means if you take a lot more of a drug, you also tend to see more side effects. The best way we've seen that it works is as an IV or as a sublingual, which is under your tongue or in your cheek, what we call as troches. So it's used in the operating rooms to give anesthesia. Now, we said that why don't we do it on our patients who have CRPS? But the problem is that you can't give them in such high doses because you're basically giving them anesthesia. So what they do over here is they give it to you in sub-anesthetic doses, which is a low dose which is a very low dose of ketamine given over a period of time. And it does decrease central sensitization. The problem is that ketamine doesn't stay in your body long enough. I wish it stayed long enough, then we would be all fine. Rough estimates, about 85% of patients show improvement in their daily activities, reduction in their pain medications, and improved lifestyles. And that's what we're looking for. Improvement in daily activities. That's the most important one. Like I said, it's not a cure. It is to be done along with other therapies, and we'll talk about the other therapies. So there are different protocols for doing ketamine infusions. There's the outpatient protocol, and then there's the inpatient protocol. In the outpatient protocol, it varies from center to center, but most of them will do it over 10 days. So every day for 10 days, you show up at that center, and they'll give it to you over 4 hours, and then for an hour more to make sure you're all right before they send you home. And the way the ketamine is given is you start on a Monday you start at a very small dose, Tuesday you step up a little bit more, Wednesday you step up more, Thursday you go a little higher, and so on. Usually what we've seen is that patients start to see a relief by day 5. I always think that if they haven't responded by day 5 or 6, I don't think we should move any further. It's done over 4 to 5 hours, and it has to be done under full monitoring conditions, which means there is a standard set by the American Standard of Society for Anesthesiologists. They've said anybody getting an anesthetic agent has to be monitored with a few different things like your EKG and blood pressure and pulse ox. These are to be monitored constantly. Of course, qualified personnel must be present at all times. I think that's a repeat. The next one is inpatient, which is called continuous infusion protocol. I believe they do it at Drexel. Actually, at Drexel they do both, the outpatient and the inpatient. It's done usually in the intensive care unit just because you need that kind of monitoring. It's a 24-hour infusion done over 5 to 6 days. the thing is, this is only done as a loading dose, the initial one, and then I think the subsequent ones are done as outpatient boosters.
The inpatient protocol is, I think it's 5 days. They start you out like at 20 mg per hour up to about 40 or 50, and then they maintain you that way for 5 days. And then on the last day, they taper you down. So it's 24-hour, it's continuous infusion for 5 days.
5 days, right? And then the subsequent boosters are done as an outpatient. You don't need to be admitted for that, they can be. But I think boosters are extremely important because once you've gotten the loading dose of ketamine, once you've got initial 5 days or 10 days, whatever it is, once your NMDA receptors have been blocked, and once the central sensitization has started to come down, the problem is that it will start to creep back up again. And before it creeps back up all the way there, you need to kill it before it does that. That's why boosters are really critical. And boosters are actually easier because they're just done over 1 day or 2 days, depending on how the pain is. Now, infusions must be done under strict ASA standard monitoring. Make sure that you have all the monitors in place. EKG, pulse ox. Pulse ox measures oxygen levels, and blood pressure can be measured every 15 minutes. This is important, as Dr. Arias pointed out. No noise, no bright lights. The reason is that, of course, one, he's right. You don't want any adrenaline secretion, and you don't want any sympathetics or stressors coming into your life. But also, bright lights and bright sounds trigger hallucinations. That's the important thing. With ketamine, at least ketamine given for anesthetic agents, like for anesthesia, it's really important that these patients have no noise and no bright lights in the room. So avoid televisions, avoid listening to your music, everything. There are exceptions. I do have some patients who actually insist on, they can't sleep, they just insist on doing some work on their laptop. But in general, it should be a very quiet room and it should be a very dark room. Now, the whole question about dreams and hallucinations, it's not an end-all of treatments. It's not a big deal. We actually like to see a certain amount of dreams, and it's mostly you see very colorful dreams, and then sometimes if it becomes worse, it could turn into hallucinations. But almost always we see some colorful dreams, and it's kind of crazy dreams. But that to me tells me that we've maximized the ketamine that you can tolerate. If I start having colorful dreams at say 200 milligrams, then that's my dose. And Jessica might be happy with, she might have hallucinations at 100 milligrams. So that's her dose. So we like to see that little colorful dream starting to sneak in. What we do is, if that happens during a infusion, the best thing is to stop it for 5-10 minutes. Give the patient an extra dose of midazolam or Versed or whatever, and then restart it. No big deal. So I don't want people get a little worried about, oh, I'll see hallucination. It's not the end of the world. You'll see a little bit of it, but not a whole lot. But what's important is rest of the day. When you go home, avoid loud noise, no traffic sounds. It should be a very quiet, dark room. You can't watch television. You can't do any of that stuff. Because what happens is, when you go home, the ketamine is still lingering in your system. And at that point, you start to, and your Versed is beginning to drop down. And that's when you start to see the hallucinations. It's always good to take a benzodiazepine pill, which is like a Valium or an Ativan or something like that, as you leave. So just before you leave, once you're okay for discharge, take one so that when you go home, you still have some Ativan or a benzodiazepine on board, so you don't get the side effects of ketamine when you're home. So there are no long-term side effects that we know. We've looked at it. Dr. Schwartzman has studied it. We've studied it up and down. We haven't seen any long-term side effects of ketamine. If you've had it for years, we haven't seen anything. The only short-term side effects you see are actually Nausea, that's a pretty common one actually. Nausea, vomiting, colorful dreams.